Dr. Margaret Baldwin is a board-certified orthopedic surgeon who specializes in pediatric orthopedics and spine surgery with an emphasis on surgical and non-surgical treatment of pediatric spinal deformity, including scoliosis. Dr. Baldwin is passionate about providing the best possible care to all our children and their families through open communication and assessment of patients and family needs. Her clinical interests are scoliosis and spinal deformity, neuromuscular disorders including cerebral palsy, muscle diseases, and spinal muscular atrophy, fractures in children. Please help me give a warm welcome to Dr. Margaret Baldwin.
Hey, I'm Margaret Baldwin. I'm one of the spine surgeons here at Texas Children's. So maybe talking a little bit about scoliosis, spine deformities, kind of a little overview on treatment, talking a little bit about surgery, and hopefully spending a lot of time on questions, answers, and other things to that effect. So first, just talking basics of what is scoliosis. That's kind of the biggest question. It's really just an abnormal lateral curvature of the spine. Any curvature measuring over 10 degrees on x-ray. It can be multiple different shapes. It can be a C shape or an S shape. And we also see some rotation of the vertebrae. There can be involvement of tilt of the pelvis too, and it can be in different locations. So it can be anywhere from up in the cervical spine, that's where the neck is, to the thoracic spine where your ribs are, to the lumbar spine, which is the part of your lower spine that doesn't involve your ribs. So looking at neuromuscular scoliosis, this is any scoliosis in a child or an adult who has an underlying neuromuscular disease. Do I need to go closer? Yes. Sorry. So neuromuscular scoliosis, any spinal curvature in a patient with an underlying neuromuscular condition. Usually a straight spine requires normal muscle balance and strength in the torso. So especially in children with either low tone or hypotonia, we see an imbalance in that muscle strength, which can lead to poor truncal control, which can lead to scoliosis. We see this more in dependent sitters versus ambulatory kids, but can be similar prevalence in both. So we have varied onset during childhood. We can see progression through growth spurts and into adulthood. The earlier that scoliosis presents, the higher the likelihood of continued progression compared to when it presents later in childhood and adolescence. Hypotonia can also worsen as children grow, so it can lead to further progression of their scoliosis. And really, the behavior of neuromuscular scoliosis is pretty unpredictable. We can see in some children, they have a small curve and ours stays a small curve. In some kids, we see a much more rapid progression. And then again, the earlier the curve develops, the more likely it's going to progress. And then there's similar findings in both males and females. So screening is basically based on a clinical exam. Biggest thing that you're looking for is any kind of asymmetry. So asymmetry in both shoulders, trunk, waist, and pelvis. So any one of those asymmetries can lead to concern for scoliosis. Development of scoliosis is usually painless. So usually you don't look for pain as an initial complaint of, concerns for scoliosis. We can see some pain that can occur when we have truncal imbalance, rib prominence, and seating difficulty, but usually it's not the initial symptom. Positive screening in any of these, seeing in the asymmetry should trigger needing x-rays and then likely an orthopedic referral for further evaluation and treatment. So for our goals of screening is really want to identify scoliosis early. The earlier the scoliosis can be identified, the earlier treatment can be started, the earlier you can get plugged in with orthopedics and knowing the next steps, and usually leads to a higher success rate. So screening can be done by your pediatrician. Screening is many times done in school settings. A lot of times physical therapists or other aides notice asymmetry first. or even parents notice it. So kind of an example of some of the screening in more of an ambulatory child is having them bend over, touching their toes, and seeing a difference in how their back looks. So when you bend over, you should have symmetry of both your rib prominences. So any kind of asymmetry of that triggers concern for scoliosis. We can also see that in non-ambulatory kids. So having them kind of bend over in their wheelchair, just how they're sitting in their wheelchair, any kind of asymmetry should trigger concern for evaluation. For one example, you can see that asymmetry when on forward bend. You also see asymmetric waist creases. A lot of times you can see asymmetric shoulders. Many times in school settings or in the pediatrician settings, something called scoliometer is used to be able to judge this rotation, especially in more mild cases. And then we classify the type of scoliosis based on the apex and the location. So it's based on the apex location. So we can see it again in the cervical, cervicothoracic, thoracic, thoracolumbar, lumbar, and lumbar sacral. And there's a lot of times there's combination of multiple different types of curves, especially more in S-shaped scoliosis. We can see curves in both the thoracic and the lumbar region. We can see curves that span multiple regions and many combinations like that. And then we break it down by category. So we have anywhere from a normal spine to more severe scoliosis. And it's done based on usually measurements and also kind of the appearance and flexibility of those curves. So a normal spine can be anywhere from 0 to 10 degrees of curve. You get to more mild scoliosis between 10 to 20, moderate 20 to 40, and then more severe above that. And then treatment is based on the degree of the curve as well as the growth remaining. So not every curve requires treatment. So kids who are closer to skeletal maturity, who have smaller curves, many times these are just observed, versus younger kids, especially kids who are still in the less than 10-year-old range, usually require more treatment, especially due to the growth potential. The big thing about scoliosis is growth tends to make these curves worse, and that's usually kind of a deciding factor on treatment. Lots of times, if there's an uncertainty about how much child has to grow, especially when they're getting older and they're in that range of they could be growing or they could not be, a lot of times we get hand x-rays. It gives us a more detailed guesstimate of growth remaining. And then chiropractic care and then dietary changes have not been shown to alter or affect any progression of scoliosis. So for mild scoliosis, a lot of times these just require observation. This is through serial exams and x-rays, and usually repeat those about every 6 months on average. It gives us a good twice-a-year screening to see mainly what are these curves doing and how are they progressing or changing or staying the same. Curves that are progressing require more treatment than curves that are staying the same. A lot of times physical therapy can be used to work on core strengthening, stretching, trying to prevent deformities. There's different methods of physical therapy, and you'll probably, if you Google it, you'll see the Schroth method, which works on muscular symmetry, angular breathing, awareness of posture. Not great for kids with more neuromuscular diseases. More you want to work on core strengthening, kind of working on the effects of the hypotonia, working on balance, kind of muscle symmetry, and making sure no contractures or other deformities develop. When curves become progressive or even progress into the more moderate range, we start talking about bracing. Bracing is not the right answer in every single child. a lot of times it depends on their tolerance, underlying factors, age, things like that. For some kids, it's a rigid orthosis that they wear underneath their clothing over a t-shirt that has buckles on it that helps align the spine in a straighter position with encouragement to prevent the curve from getting worse as the child grows. Sometimes this can also look, bracing can also look like modifications to wheelchairs and other sitting devices. So bracing and custom backs can be built into the wheelchair itself to provide a more supportive seating, which acts like a brace, except most of the time is more comfortable. When we start bracing, the goal is not to improve the curvature, but to prevent the progression. There are very different types of braces like talked about, either braces built into wheelchairs. There are softer braces, there's more rigid braces, or braces that are worn at night. A lot of them depends on curve location and the kind of discussion with the physician and the tolerance of the child. They're usually worn until the curve progresses to either surgical magnitude or the child stops growing. And then when we have more severe scoliosis, this is curves measuring over about 45 to 50 degrees. Then a lot of times you start talking about surgery. Surgery is tailored to the child, tailored to a lot of underlying factors. So in not every curve that's over 45 degrees is a surgery initially offered. And very young children, a lot of times we try to wait until that child matures some before offering surgery. And then older children, sometimes that's more offered right away. So a lot of it depends on there's not one treatment that fits every single child. So it's not once the curve reaches 50 degrees, you have to have surgery. It's more of, it starts becoming options. And the biggest option is we want to prevent the curve from continuing to progress. And usually once curves hit that 50 degrees, we see continued progression of the curve, even through adulthood. So that is our biggest concern. And also the risk of pulmonary issues and pulmonary compromise once the curve reaches over 80 to 90 degrees, as well as pain and sitting discomfort, especially as these curves reach over 100 degrees. Posterior spinal fusions are the most common surgical option. So what this means is a surgery that goes through the back part of the into the spine and uses screws and rods to correct the curve, but the main goal is to prevent curve progression. There are different types of constructs, different types of options, all usually based on curve, child age, and surgeon preference. You use, especially in kids with underlying neuromuscular diseases, there should be a multidisciplinary approach. There should be involvement with pulmonologists, so the pulmonology team, the neurology team, the anesthesia teams, all working together to make sure that the child is ready for surgery and is going to have a successful outcome. A lot of times we work with GI and nutrition to help with weight gain, to make sure that kids have enough weight on them to have a good surgery. Lower weight can lead to higher complications. So a lot of times if you're talking about surgery, you're in the process of surgery, you're going to see a lot of different teams, especially teams that you haven't seen before and may not need to continue to see afterwards, just to make sure that we don't need to optimize anything better to have the most successful outcomes. There's really no age limit for surgery, but surgery does have a higher risk as patients age. And this is really kind of, when I say age, it's over like 25 to 30, more in the adult range. So spine surgery in adults has a higher risk of complication than spine surgery in adolescents and children. Also, with neuromuscular diseases, we do see early onset curves. So this is any curve under the age of about 10. A lot of that depends on skeletal maturity and other factors, but there are other options of surgery that allow for continued growth, especially in large curves in younger children. So the goal is to be able to optimize truncal height, space for lungs, and to prevent future pulmonary issues. This usually does require additional surgeries as a child reaches closer to skeletal maturity, and sometimes other surgeries for implant exchange or other issues. But this does allow for curves to be controlled as a child gets older. So a lot of times this is starting to be talked about as we have young children with a lot of growing potential left and unable to control the curve by other means. So when we talk about surgery, you also talk about recovery. So the hospital stay can be anywhere from 2 to 7 days, sometimes even longer, depending on complications following surgery. We usually have kids either sit up on the side of the bed, sit up in a chair, sit up in their wheelchair, or even stand the day of surgery, and then they progress with their ambulatory function. Prior to going home, pain is controlled. They have adequate pulmonary function and not requiring any oxygen. They can ambulate at their baseline and tolerate food and liquid. We have limitations to bending, twisting, and lifting for the first 6 weeks. And then they're able to slowly return to their activity starting around 6 weeks. That usually includes physical therapy and occupational therapy at that time. There's no contact or collision sports following surgery, and there's some limitations with forward bending following surgery. These limitations change based on the amount of spine that we have to operate on and can be different from child to child. And that's all I have from my kind of formal presentation. So I really want to open up the questions and concerns and kind of see what questions have arisen from seeking treatment, other things like that.
I'm Lila. I'm 17 and my spine's 28 degrees.
Mm-hmm.
Can it be like fixed?
So when a curve is kind of in that moderate range, there's not a great option to make it straight besides a surgery, which is usually not required at kind of that degree. But if you're having symptoms or pain or discomfort, there's a lot of good ways, like through physical therapy and other methods like that, to help you feel better.
So it can't be fixed?
Can't be made straighter, but if you're having symptoms, we can fix those. Do you have a question? Oh. No, you don't. Go ahead.
Just to follow on Lila's question, it seems like the gradations, multiples of 10, are somewhat arbitrary.
Yes.
And that I believe you said the younger the curve is noted in the development, the more potential there is for things to get worse. And the screening should be at least every 6 months.
Yes.
So my question is sort of an invert of what you said, which is, let's say it's only 8 degrees, but the child's very young. Well, at 8 degrees, you've not yet to minor, so you wouldn't even be doing screenings?
So that's kind of dependent on every kid. So even with an 8-degree curve, if they have an underlying neuromuscular condition such as HADS, I recommend continued screening, whether that be with orthopedics or with the pediatrician, just someone continuing to monitor. Even if it's not in our range of this is scoliosis, you still have potential. So even if you get screened and they say, oh, you don't have scoliosis, that doesn't mean that screening stops then. It means it should continue being watched. These symptoms should be watched out for by the pediatrician, by family, by therapists, just to know that someone is watching for any progression, even in orthopedics too.
You had mentioned core exercises for working on or fixing the spine. If they start there early when there is a slight fear of a scoliosis developing, will that kind of help it to not develop?
So that's a hard question just because a lot of times we're not it's hard to 100% reverse the underlying hypotonia. It definitely helps. It definitely helps provide a stronger base and stronger support for the spine. Whether that completely eliminates the risk of developing scoliosis, I'm not sure, but it's definitely helpful versus harmful.
Hi, thank you for your talk. This is really interesting. And I have a couple of questions. So one, I was just curious, is there a typical like range or age of onset, or is this something that can just happen at any time? And what like causes, like why does this even occur?
So not a typical range. You can see it anywhere from very young kids to more when they hit their adolescent growth spurts. A lot of it is dependent on some underlining kind of how much hypotonia they are, depends on ambulatory function as well. And some kids were just not sure why their curves developed at a younger age. There is a thought it's due to the underlining truncal weakness and not having the truncal muscles that allow for 100% support of the spine. But there's always other thoughts, especially with rare diseases, with genetic abnormalities that is there tied to the gene itself that leads to development of the scoliosis or appearance of curves. And that's not sure. We think that either idiopathic scoliosis, so and more in like neurotypical kids, there's some type of genetic link, yet we haven't determined that. So maybe there's some type of connection between a lot of these genetic disorders that have a propensity to develop scoliosis. So I know that's a lot of, I don't know, but there's multiple different factors.
I think.
Thanks for your talk. I had a question. So my daughter is 6, and we've never had any kind of formal screening or any red flags come up for scoliosis, but know that it's a risk factor with HADS. She's seen by a pediatrician. We've never had them specifically look for scoliosis, but I'm pretty sure even the screening that you suggested in terms of bending over would not raise issues. So in that kind of case, like, should we be seeking more formal screening and doing it at regular intervals? I wasn't clear at what point. And also hypotonia has not been a big issue as much.
I would say
But just to add to that, on it's de novo HADS, but on my side of the family, there seems to be genetically a recurring scoliosis.
So there's kind of then 2 risk factors. I wouldn't, if there's no concerns with kind of what you see with her or what the pediatrician sees, I don't think formal x-rays are needed, but I would make sure that the pediatrician is aware that she has a higher risk of developing scoliosis so that the pediatricians can start watching for those symptoms, looking for things, monitoring earlier so that they know the look. Sometimes some pediatricians won't start screening more until their adolescence, which is more for like neurotypical kids. That's usually when we see this versus kind of younger kids with neuromuscular disorders.
Just one other question. In terms of age of the same sort of similar question of age of onset, it could be like if you're over 10, the risk reduces, is it?
It depends on growth spurts. So a lot of times we can see scoliosis develop with that adolescent growth spurt. So that a lot of times 10 or 11 with girls, a little bit later for boys. So that risk doesn't go down after 10, but the older and older kids get, the lower risk there is to develop a new scoliosis curve.
And if hypotonia was not an issue initially, does that substantially reduce the risk of developing it in the first place? Like would you have to have at least moderate hypotonia to be at significant risk, or how does that?
So based on other studies, there's not a ton as you know, kind of research on exactly HADS and scoliosis, but based on other neuromuscular conditions with that truncal hypotonia, we see the stronger truncal control, so the lower prevalence of hypotonia, the lower risk of scoliosis.
Thank you.
I have a question, semi-related. Dr. Chow has talked about how a lot of these individuals with HAD start off with hypotonia, and then as they get older, it ends up being hypertonia and everything starts tightening up, which has also presented then with contractures, et cetera. And so in general, what, like at what point should a family seek out an orthopedic? And even if a corrective surgery would be in order, kind of, again, in general, what is that process?
Yeah, so I would start seeking out orthopedics as soon as there's a concern. At least for me, I like seeing patients earlier, being able to establish with the family if there's other interventions that need to be done, like bracing or things that we can do to prevent curve progression. I'd rather see families early and establish that before you see them with a big curve and automatically are talking about surgery. Like to try to do everything possible to try to avoid that. So if we get to the point where we have a big curve, we're starting to talk about surgery, usually the first step, especially at Texas Children's, is we start getting you into our kind of subspecialty clinics. So we have you start being evaluated by pulmonology, by anesthesia team. We start talking, you know, about any other subspecialist you may need to see and start trying to figure out how we can medically optimize children. How can we make them the healthiest? Do we need any kind of supplemental respiratory support at night? What do we need to do? And that's usually our first step. And then we kind of progress from there.
My daughter is 9 and she started out even before 1, she had a leg length discrepancy and we thought it was because of bones, and we found out probably 4 or 5, it was more like in her hips. It was neuromuscular, and so now it's a lot less. However, now she has an issue with what her right shoulder higher than the other. We've done physical therapy on that actually just recently, and it helps a lot. So we probably know it's due to the hypotonia. However, my issue is my nurse practitioner ordered an x-ray and was thinking it was possible, you know, is it scoliosis? That came back negative, however, but we're having a general radiologist take a look at it. Should I have her see an orthopedist once a year or something, since she's so high risk?
Yeah, so general radiologists are usually very good kind of just identifying and doing the initial screening on looking at x-rays and determining if there is a curve. I think that for kind of seeing orthopedics, it's really dependent on kind of personal preference. I think trying to minimize the amount of x-rays and other intervening factors is great. So having kind of your family pediatrician look, and then if there's a concern or if there's a change, then ordering x-rays.
Thank you.
Versus if you come to orthopedic clinic, a lot of times you'll get x-rays. So I'm good. Awesome. Thank y'all.